Call is going to be for scoliosis, and Tricia has the most common kind of scoliosis, which you guys probably remember is what kind?
The right one.
Right thoracic. Good. So that means the convex side goes towards the right in the thoracic area. And can I have a vertebra and a rib, please? The giraffe and its nose goes down. Remember, the little spinous process goes down. So on the convex side, remember that the body of the vertebra is going to rotate towards the convexity or the convex side, which of course in the thoracic region is going to bring the ribs with it. So in moderate or severe cases, the rotation of the vertebra that goes along with the lateral deviation off the mid-sagittal plane is going to bring the ribs posteriorly on this side, and then of course anteriorly on this side. And you probably remember from the diagrams yesterday that that actually decreases the space between the ribs on the concave side and kind of widens them and brings them posteriorly. And then of course here's the medial border of the scapula, and here's the medial border of the scapula. That tends to also move the scapula in a different position. In the hips, what is most common to compensate is that the left hip will get elevated and the left QL will be tighter and shorter. Now, because of scoliosis, yoga for scoliosis and yoga practice, Tricia knows how to compensate her muscles pretty well. But Tricia, could you stand in a really lazy posture? So if Tricia was to really let her curve kind of get the better of her, this side would get shorter and tighter and elevated, and then this would get exaggerated. And then she knows how to tighten the correct muscles to correct a lot of her injured arm is also hurting right here where this is medially rotated. So you guys already have good palpation skills, but with the bony landmarks of scoliosis, with the bony landmarks falling in different locations, you might want to close your eyes to really feel the landscape, the shapes of where the mountains and plateaus, peaks and valleys, feel where everything actually falls. And you guys don't tend to do a lot of this sort of stroke anyway, but a lot of massage therapists will do a lot of, like, and this is an extremely slowed down and very, very light version, but a lot of massage therapists will, do this sort of thing on the back. And if the spine is not aligned with the mid-sagittal plane, you don't want to do that, especially not deep and vigorous, because you'll be bumping into bony landmarks and you will not be really following the erector spinae, the rotatories, and the multifidi. So if you do that sort of bilateral warm-up, you want to have your hands follow the curve and where the erector spinae are. Many of your clients are going to have mild scoliosis, in which case the curve is not that different. But in moderate or severe cases, the rotation that accompanies it with the vertebra rotating and the ribs coming along in the case of thoracic, when you come upon, and if you're assessing, like here we would typically assess, and you can see visually left and right down here in the lumbar area that there's a bigger speed bump on the left, and normally you would assess that as the erector spinae, and it's flatter here. But in the thoracic region, when you see that kind of larger speed bump on the right than the left, this is actually going to be the ribs. and not just the erector spinae. And when you're palpating what you think is the spinous processes or the transverse processes, they're actually rotating quite flat in this direction. And so what you're palpating is actually more like the ribs and TVPs and so on. Now, most clients, when they have a shoulder that's tighter or more elevated than the other, let's say we have a right side issue, thoracic or shoulder, in almost all clients, that's going to be balanced by a left side tightness in the lower back and hips. That's a normal way for the body's architecture to balance itself and compensate in space and gravity. And you see that pattern here with scoliosis, but you will see that pattern with many of your clients who do not have scoliosis as well. So one of our focuses is going to be here in the left lumbar. Once the area is warmed up, the QL, and the abdominals, the transverse abdominal, obliques. And then the thoracic region. And I wanted to do a teeny bit of warm-up and assessment so we could see that visually. But now we can warm up this area with a hot pack while we focus on the shoulders. And since the left is tighter than the right in the low back, I'm going to have the hot pack actually go around the side so that we're warming up the lateral muscles like the obliques, the abdominal obliques. Is that comfortable there, Tricia? Mm-hmm. You let me know if it gets too hot. When we were doing the scoliosis PowerPoint yesterday and looking at different diagrams, looking at different compensation patterns, you know, we got to the point where it seemed like pretty much all of the muscles were implicated. But over in this region, just as a reminder that whenever you throw a shoulder anterior or posterior to midline, the rotator cuff muscles are going to hold on for dear life. So the rotator cuff muscles are going to be tight. And I'm starting off super gently here, mostly for the demo and because it's been a while since I worked with Tricia. But if her style preference hasn't changed, we're going to probably pick up the intensity as we mobilize the scapula. I think when the bony landmarks are falling in slightly different locations, one of the times you have to be more careful is when you're using your elbow or forearm, especially when you're entering and exiting strokes or transitions. Sometimes there might be a tendency to get a little bit sloppy and sort of just kind of land a little too intensely, and you don't want to land on a rib that, in the case of the rotation with the scoliosis, is going to be more vulnerable. And it was actually her right shoulder that currently has a little bit of supraspinatus injury. So we could start right with the right side, but Tricia and I used to work together a lot, and we oftentimes would start with the left side. Sometimes when you have a client that you've worked with before, sometimes their body kind of responds faster if you kind of talk to it in a way that it's used to. It's kind of like an old friend, or the way you say hi to your dog, or I think she liked the first one better. But her supraspinatus got soft really fast, so that theory seemed to have worked in this case. That rather than jumping right to the injury, go to something familiar. Of course, infraspinatus, teres major, teres minor, posterior deltoid. And Tricia works with her breath super well from her yoga training and practice. But you, as the therapist, of course, should be working with their breath as well. For example, you saw her take a nice, long, deep breath. That would definitely be a time to continue the stroke that you're doing. And if you were steady, to stay steady until they finish letting go. That would be a very bad time to stop and do something new. And Tricia, on a scale of 1 to 10, if 7's perfect, 10's too deep, 1's too light.
6.5.
Okay. You see the nice pinkness all the way down into the arm. And may I be looking in front of your shoulder as well? With my hand in front of your shoulder. Couple of reminders when you do scapula mobilization. Your goal really is lengthening the muscles that are too tight and short and increasing the mobility as well as the smooth movement of the shoulder, not just seeing how far underneath the shoulder you can get. So for example, Tricia's would go up quite easily, and you'll see that in a second. But what we actually want to do is release the areas that are tight and short, and as we increase the mobility of her shoulder, continue to release the ones that are actually short and tight, not just see how far underneath her shoulder we can get. Another thing is generally, we've got a floppy arm here. You want a lot of support under this arm as you're going to start to move it around. And then a little tighter spot here.
Which muscle exactly are you working on right now? Teres minor or pec or delta?
Subscap.
Underneath that.
I'm not answering you, Serge, because I was focusing. This is intense for her, so I want to be very focused whenever you're on someone's edge. You don't ever want to cross their edge. It's pointless. It adds guarding. it's counterproductive. And soothe out the areas, make nice, integrate the work, find the related areas that are tight. The friends in the neighborhood that are upset about the situation. Is that position of your arm okay?
Yeah, it's fine. Trigger point.
And intensity on the scale of 1 to 10, 7's perfect.
It goes from like a 5 to a 7. That's good.
You can intersperse your deep specific movement with really moving the scapula around. The inferior angle is an excellent handle, and you can use it to help move the scapula all the way around. You can use it as a place to get under the medial border. And again, my point is to release the areas that are actually tight and increase the mobilization of the scapula, not just to get under deep. Because if the scapula already lifts easily, just hanging out in the spots that are easy to get under aren't really going to do a whole lot. So we're working our way up to the areas that are a little tighter. And now I'm pulling it towards the ceiling off her body. And does that feel comfortable? You see I have my elbow against my hip for support. And you can see the lift we have on that. You can shimmy it sometimes. And feel free to move their arm off the table as well. Integrate the work. Feel good pulling it in that direction? Sometimes there's some little spots in the deltoids that respond well with origin and insertion work. Intensity?
About 8, but it's good. I mean, it's a good 8.
How's that?
It's good.
So there's a nice tight spot here. Do you like that better moving or still?
Either one's fine.
Okay. See that little jumpy one right there? See how it jumps?
Yeah.
It's probably got a trigger point in it.
I heard you said trigger point somewhere.
Here. And I could talk to lengthening her whole arm at the same time I'm talking to the deltoid, which is jamming her arm up into its socket. Or I could talk to the insertion of deltoid, the deltoid tuberosity. Right now I'm adding a nice little tractioning to her arm. Any intensity, Tricia?
Perfect.
Do a little petrissage to flesh out the deltoid. Too intense?
No, it's good. Massage therapist arms.
And then the fascia of the deltoid has the exact same attachment as the traps of the clavicle, acromion process, and spine of the scapula. Only one attaches distally and inferiorly, and the other proximally and superiorly. So it can be nice to talk to both of them at the same time. And that can be sort of like the piece de résistance of releasing the rest of the traps. So sometimes people forget to talk to them right up here.
What was the French part?
That's like the icing on the cake, the very best part. How about Russian, Ukrainian? ¿Cómo se dice en español? Like the very best part, the cat's meow, the parte más mejor. The best part. Oh, not an expression, just the best part.
Черешня на морожені.
Черешня. The cherry on top.
Черешня на морожені.
Черешня на мороженое.
Cherry on the cake.
French sounds better.
La piste de résistance.
Or черешня на торті. Черешня на торті.
Черешня на торте.
Cherry on cake.
Nice.
What is the one you say? What do you say for really tight scalenes and later scapula?
French?
La vista.
Not so good.
Too much?
Yeah, 8. There we
La
go.
vista esto no es bueno.
Pushing, shoulder, pulling.
Yeah. And this will give a lot better functional change than if you just kind of do little isolated things. So I could see that this was very much connected to the shoulder's unhappiness. we'll get some of the supine because there's a lot there. Surprised you held back from saying you think?
I'm on video. I have a towel on that side. That way I don't have to obsess over it.
Ooh, you hear that? There's a little clicking.
It was my neck.
Was it you?
Yeah.
Were you clicking too, Trisha?
I didn't feel like I was clicking. The other side will click. The other side
I had a
clicks a
click
lot.
too, just saying.
All right, well that is quite mobilized, and I think we'll call that one good because the other side needs attention too. Let us not forget.
Oh, where is the rib that she's having trouble with?
Right about here.
It goes right underneath the bottom of the scapula.
So we're going to integrate this a little bit, even though the low back's only been warmed up with the hot pack so far. And actually we're going to go to the spot that's still troublesome in the neck. Contralateral shoulder and hip is an excellent strategy in many cases.
At the end of my elbow.
Uh-huh. Just be careful of the bones. And my left hand is carving out just lateral, basically the deltoid. Coming up to the iliac crest, we want to make sure that we lengthen, which will actually move the hip. And I'm following the pattern now of what is actually tight laterally.
And this is the elevated head?
Yes. And talking to supraspinatus and traps at the same time. With that supraspinatus injury, you could dive right in, but it would be wise to get the traps happy first as well. And then supraspinatus, of course, abducts the shoulder.
Low rib.
Thank you. Sorry about that. And so you got to think about what else does that. The deltoids also abduct. So we're going to make sure we don't just talk to supraspinatus, but also the deltoids and the traps. And indeed, the deltoids are feeling a bit overworked. A little extra tight, a little extra stringy. And in some places there's a little wall of tissue. Things feel actually more bound up more medially.
I was playing with the cups. I was noticing that I could make a toe on the subscapularis
Uh-huh.
on the medial border.
Ah. Okay. Too much?
Left hand is right in the trigger point nerve area.
How's that? Okay. When it's a little intense and sensitive, you can also take the tissue behind it. Go a little bit easier on the pressure hand and use the tissue behind it to push into it. For a trigger point there. That did a tremendous amount for releasing the fascia in this area that was incredibly bound up. Now, there was a whole wall, this whole area, and now this part's got a lot more movement, and then there's just a wall right here where there's usually that little traffic jam with levator scapula and traps. And if we get isolate levator from the little tangled mess it gnarls up with. So if you have to really isolate it, you can use the inferior angle of the scapula, jostle it around, get anterior to traps, jostle this business around till you get right to the superior angle of the scapula, and very much isolated right on levator, and then follow it up or down, and it will give a much more specific release. To levator, you'll lengthen it and find its trigger points easier than if you just talk to the whole gnarly mess at once. And I say gnarly mess with all due respect. It's that way on probably 80 to 90% of your clients. All right, so my superior, my thumb, is helping jostle the tissue. My finger underneath is the one that is actually right on the levator fibers now. And it's going to feel a lot more like talking to pec minor than when you talk to the whole mess at once. And the intensity, Tricia?
It's a 7, but it's intense, yeah.
Following some tight fibers up. And if you're following the right muscle, it'll take you to the TVPs. If you got sidetracked on one of the other cervical muscles, you'll end up more posterior. Right on the TVPs now. So if you feel any numbness or tingling or shooting pain, let me know, okay, Tricia? And I'm sneaking up right behind them. If I was sneaking up right in front of them anteriorly, I'd be catching the junction of the scalenes here as well. Integrate and assess. That mess, of course, gets tangled up with supraspinatus as well. So releasing that well is going to help the supraspinatus problem, but there's a gnarly little mess right there. How's that?
You can go in deeper. Right there.
You can talk to deltoid at the same time. And you can jostle the shoulder girdle around to get right up in the supraspinous fossa. And this, just if you've lost track, this is the side where supraspinatus has a little injury right now. We'll do a little MFR with deltoids at the same time. Jostle it around and elevate the shoulder to put this in a softer position to find some of the tight spots. There's some trigger points in there.
Just a few.
Between, I'm flushing them out and reassessing. You can get your stretching, your post-stretching after trigger points with MFR even. This, as I'm working the fascia and reassessing, seems very much tangled up in the medial rotation of the shoulder, and I can feel a lot of hitches right here. So rather than just pulling the shoulder down inferiorly as a stretch, I can feel that it's tied up in this little tight tangled spot anteriorly, so I need to release that first. Thanks. And I can tell this is an easy place to turn up the volume. So I want to ease in. There's a lot of stuff bound up here. Any intensity, Trisha? Sorry. So when you skirt the edge of good pain, good intensity, edgy 7, it's really important to be 100% attentive, because this isn't just like a game of like taking people to a 7. If you're on their edge, it's very easy to accidentally cross over, and you want to very respectfully facilitate releases in the tissue, not just sort of like, oh, there's intense, oh, there's a messed up spot, there's a messed up spot. And this would be a good time for a glass tabletop modestly covering people, because the spot is right here anteriorly. That's where it is tight, which you can't see what I'm doing with my hands. It's superior to her breast tissue on pec medial, right through there. And there's a very bound up spot that's totally related to how it's stuck here and here. So I'm going to open that up. And we can move her shoulder, you know, as we need. And areas where the muscle's relatively thin and the bone's right there, you want to be very cognizant of engaging and grabbing the fascia and the muscle and pulling on it rather than just going like deep, because you can easily get into the bone and sort of bypass that tissue engagement. Oh, that's nice. This anterior deltoid, whoo boy. You may recall that the anterior deltoid medially rotates in addition to supinating, so she's got double time right now. She's got that supination. I'm saying supination and I mean abduction. The abduction connected with the supraspinatus, and then the medial rotation, and you saw how that shoulder was medially rotated more than the other. So you got to open that up. And sometimes it can be helpful to move the arm. And just like you would in the low back, to sit back with the stretches. Once you have a good spot, you want to sit down. Too much?
It's okay. It's just I can feel it all the way to my spine. Like a fascia pull.
You got some fuzz there. Fuzzy fascia.
Your scapula.
And whenever you do this kind of pulling, it may look like I'm just sitting down, which I am, but I'm using my thigh muscles, well, and a lot of other muscles as well, but I'm using my muscles so that I have control of how much pressure and pull is on, and I'm not just like pulling with my whole body weight. And it's more controlled that way, that you can give the client the right amount of pressure, and then you won't need to go to the gym that day. I'm doing my squats. Cross training, check. CrossFit. You know, the fuzz video is on our website, but I didn't show it in class yet. In your MFR section, there's a really good short little video on the top called the fuzz speech. It's really short, but really good.
Is it funny?
Yeah, it's funny. That's why she's still laughing. All right, now we have the deltoid. Much more isolated. It was bound up to everything. Remember, when you're doing MFR and all the other tricks you do, a lot of times muscles get all stuck to each other in ways they shouldn't. So sometimes you're carving them out as discrete, separate muscles, getting rid of the cross bridges that should not be there, and then lengthening them. Too much.
That part right there. Yeah.
This one right here. Let me do it slower then. How's that? look at that. Much happier. See all the spots that are happy now? Now you can find any spots that aren't and isolate them. There's still a trigger point right there. And if I was a betting woman, I would say that's connected to this, so I can connect them too. Don't give away my Batman. And the intensity, Tricia?
7.
Let's see how the shoulder wants to move. There we go. Christy, you're slacking. You used to fix my hair. I can't get good help these days.
Snacks.
Snacks.
My towel.
What's that?
Can I get the towel?
Okay, I'm blocking you, but okay, sure. How about we take the hot pack out of there and all that out?
Just throw it somewhere.
Mm-hmm.
You're in good hands.
Can I put my leg under your arm?
Mm-hmm.
The towel might be in the way. I can try. Yeah, that's not the right angle. Thank you. I'll work around it. I'll be good. That's it. Oh, what's going on here? Where is it stuck? There we go. That's where it's stuck.
Right there. Oh.
Right there. Not so easy, Tricia. Can try to push it out, but it's not going to work. There we go. That's it. So one of the tricks to getting the shoulder elevated well enough to work in the spots that are tight is actually a lot of it is to do with the hand that's underneath. So rather than just sort of randomly putting your hand cupped in front of their shoulder with their arm on your arm, you want to actually move around where your hand is underneath and actually change the angle of the scapula underneath like so, so that your bottom hand, see if I don't do that, see how flat it is? A lot of the angle is all from my underhand. My overhand's not even doing anything yet. So I want to position underneath and rotate her and lift her so that I can actually do that and get to the spots that are tight. So get a lot of that done with your hand that's underneath. And now we're in the spot that actually needs help. And hers is elevated or off her body enough that I can go right to the tight spot. But let's say I couldn't. I would want to take the spot that I can get under easier and sort of shimmy my way up from there, which is a good way to see what's tight anyway. There we go. And you can jostle, use both hands to jostle, to sink into those spots. There we go. Now it's going to pull. We're going to turn up the volume here. Tell me when we're at 7. That's your cue, Trisha.
I know. I mean, it's all feeling good. Yep. Like maxed out though.
Okay.
A little more if you want.
Yeah?
Don't take it.
What's that?
So just don't take that stuff.
Just don't take one?
Energetic stuff that's like releasing. It's like,
Oh. I'm not taking it. You see me blowing it out?
Just taking the chi away.
just the bad stuff. I put on my protection oils this morning.
You can take your chi away.
I did too. Too much?
I don't think so. Close. And she squeaks, that's why it's
Shoulder's gone.
I can't watch.
It was way out.
Wow, this part's amazing. Check that out. Now we're going to work out the crunchies. There's some residual crunchies. I can practically hear them. Crunchy crunch, crunchy crunch.
I have a bunch of them.
Jostle, crunch. There's the superior border. Oh yeah. It's tied into your scalenes.
No.
Ooh, look at that!
Yeah.
Take that, superstinatus. Alright, and then usually there's some stuff here left at deltoids. And I'm not a huge fan of cross-fiber friction, I will admit it on camera. But one of my favorite places to do it is the deltoids, at the attachments. So you saw off the layers or shave off the layers like your Snoopy snow cone machine.
Sound effects.
Glad sound effects. We're shaving off layers.
There's a car.
Sounds like a sanding belt. That's tender.
Right there. Could probably make this one jump so you could see it, but there's a real tight one right there. And that's actually not releasing all the way, just with the cross fiber. So I'm going to talk to it a little bit more. And since it's pulling up towards the shoulder, we might have some luck lengthening it down.
Bending it doesn't hurt?
Yeah, I have it supported, and I
Oh.
just can't, my thumb does that easily.
Okay.
All right. Always something left in Terry's minor. You can guess that pretty much on everyone. They're way up high. We're going to lose her hand so we can do it for her. It seemed better actually like this. I'm going to remove this towel. It looks a lot better.
It feels
Squishy.
We totally missed that on camera, Tricia.
What?
Our camera was walking away.
What did we miss?
How amazing it is.
It's very amazing. It feels so much better.
What was that?
All right, so we were talking to Terry's minor. Needs a little help way up high. There we go. Curl right in there. We already know scalenes are implicated, so we can start to talk to them at the same time. We're going to hook in to the fascia. And you could very much do this from the other side of the table if pulling doesn't work for you.
You want tissue or something?
No. It's not moving anywhere.
Take it to its edges, all the way around.
It's right in
This part?
the lower part, yeah, where your pinky is.
Okay. All right. Bing. So shoulders are much happier. Usually you want to work this area really well. This is good side lying too. All right, so when she was prone, we already started to warm up the low back with the hot pack and then a little bit of Swedish. Before you dive into the QL or the deeper abs or iliopsoas, you want to make sure that you actually do indeed warm up the superficial layers. And with elevated hip, the QLs are going to be tight. Or if it's one elevated hip, the side that's elevated, that QL is going to be shorter and tighter. And you can work the QL as you've seen prone, but a lot of times side lying is easier because the fascia of the thoracolumbar aponeurosis is so dense, and the ESGs are some substantial muscles as well that you're going to kind of come around the side of the ESGs to get in front of and straight into the QLs anyway. So sometimes this position is easiest. And then this position is also great for releasing the sideline of the fascia with the anatomy trains, the abdominals, and iliopsoas. Now, when I start to work the abdominals and iliopsoas, I can work through the sheets in front, or with the client's permission, I can work under the sheets or move the sheet anteriorly. Whenever you're anywhere here on the side where you might accidentally, or the sheet might accidentally move, you've got plenty of ways to just hold the sheet down yourself. So you can hold the sheet down with your own hands. Now, in this position, on a lot of people, their ribs come right down low, and in some cases, their floating ribs even kind of touch their iliac crest. So when you start to do some squeezing or isolating or MFR, really any kind of movements in this area, you can be very conscious of where the floating ribs are and not just be jabbing into them. A lot of your movements, you're going to actually be rotating the hips as you work. And of course, a lot of people might be ticklish in this area. So you want to use really confident, heavy, steady, broad hands. And for example, my anterior hand, part of it is on her ASIS. And if I had really horrible palpation skills, and I felt like I had to poke around to find stuff, you don't want to use little poking movements, because that, of course, will be ticklish or make their muscles jump or make them feel uncomfortable. But these muscles wrap around anterior all the way around the front of the iliac crest. And when you really want to help facilitate rotating the hips, this is such a great position because you can get around the front, the top, and the back all at the same time. And then move their pelvis. If you're shorter, you might, at least I do, like to get pretty close to this work. Sometimes, if the client's permission, I'll need to put my knee on the table, or I got the stool out in case I need to be a little bit taller. And I'm right up against her ribs here in the front, so I'm carving them out, but I want to be careful not to push on them. And there's a very nice tight bit of fascia right here that I'm going to engage. And if I feel like I need more leverage, I can stand this away from it. There we go. And these muscles and the fascia obviously are going to get woven right into the periosteum of the bone. And so you don't stop at the bone. The bone actually becomes a handle. But as you do your MFR, you're actually rotating the hips. And I can feel that pulling into the front fascia right here as well. It's a bit bundled up. This bundled up sheet is in the way of the fascia. So I'm just going to flatten it out. So right here's the top of her iliac crest. Right here's her ribs. And I'm going to get on the fascia of both sides. Squeeze in. Up and out. But I'm going to actually be feeling the whole time the patterns of what is actually needing the pull, rather than doing the movement randomly. And I'm finding in the back there's a nice wall of tissue. Probably would be happier not as a wall, but only time will tell. We'll just talk to it and see if it wants to soften up and lengthen or not. This is where we get into the Holy Mother of God work.
So, first person.
It feels really good to let go of stuff in this area, but it can also be vulnerable. So again, this is not like a contest of when you can cross somebody's 7 or haha, look how deep I am. You really have to hang out with the client and see exactly what pace they want to let go of stuff. This is, after all, about them and not you or your ego. They have to choose to let go of this stuff, so anytime you start to try to force it or muscle it, it is counterproductive and often detrimental. Okay, so there's a little bit here.
Is that one spot?
You're not asking her what, how do you...
I'm watching her.
He knows.
10, 11.
She responds every time I move.
Certain parts make her look more relaxed even though it's intense, and certain parts make her look more tense even though it's intense. And parts of it make her jaw tense up too. So I don't want to do anything that makes her jaw tense up. That's an example of counterproductive. So sometimes what I'm doing here is like, yes, there's a certain spot that seems as if it probably wants to let go, but we have to work around everything else that needs to happen so that it can go. And if we don't get to that place today, that's totally fine. I suspect we will but if guarding comes up other places, then that's not good. And guarding in the jaw is super common. So I'm taking the same part of the pattern that was upset, and I'm sort of tricking it by pulling it the other direction. And that keeps her relaxed. Nice deep breath, you wait for it. And your hand position, of course, is going to be different. Obviously, the size of your hand, size of the client, exactly where things are tight. Sometimes you can get your whole forearms involved, or bigger parts of your hand, even your fist, whatever tool you need to get in there effectively. And this is a really nice position to have the whole leg, ASIS, as part of the leverage and stability. Traditionally, what a lot of people do is kind of jump right into the QL without even releasing the abdominal muscles or the lateral line.
It's not nice to do that.
And it's not nice to do that. It's not. So I'm assessing what here is soft. What's still holding on? There's definitely psoas stuff. But I would be a fool to jump right into psoas stuff. May I put my knee on the table?
Do I need to move forward or anything?
No, you're good. And actually, may I put both? One knee and one foot? Scary?
Yeah.
For who?
That's you. No, that's some good abs.
For me?
Yeah, it looks like you're gonna fall. That's some good abs.
Abs?
Sure.
And you definitely do not have to get on top of the table for this, especially if you're taller or the table's shorter. For example, if you were only doing side lying, you could set the table shorter.
Some of you can.
Some of you can't get the table that short.
I massage mats as well.
Mm-hmm.
Did you say Trisha? That's supposed to.
I massage mats.
All those deeper muscles like subscapularis, pec minor, iliopsoas, and QL, you have to talk to them slowly. They're postural muscles, and when they get overworked or fatigued, they shorten in response. And we can engage the fascia at the same time. kind of broadens the effect. Takes a little bit of the intensity away. Mm. In addition to being really slow with these muscles, you always want to hold therapeutic space. And particularly, but always, but if you were to get on top of the table like me, you want to hold therapeutic space. So you don't want to do goofy things while you're up here. There we are. We're at another level. Some massage therapists like formulas. And if you like formulas, you want to go through about 3 levels of depth.
What do you mean by formula?
Like a specific routine or protocol to follow. Like, well, how long should I hold it? Or so you should go through like 3 depths of release.
So kind of like the
Yeah, kind of like that. Only it like released to a whole nother level. I'm gonna scoot forward a hair.
Are you doing anything with your left hand?
Just being supportive and listening. There we go. And you can often work just above the iliac crest, but then you can often get right down to the transverse processes as well.
And where she's at, I can feel it all the way through my abdomen. I can feel it pulling off organs. I can feel it. Wow.
You can see the finger.
I can move the sheet. It's to the TVPs. And it's really close to the floating ribs, so you have to be aware of.
That way you can't see anything. Go sit somewhere else. Sorry, it's distracting.
Doing some kind of MFR afterwards can be nice to lengthen, to integrate, to make nice. You can get a handle on the top of the hips, like so, and however you are with your other hand.
Ooh.
Careful with the ribs. Those of you who are really tall might even stand on the other side of the table for this. Yes. And oftentimes it wants to spiral. So rather than coming straight down, it will often be more receptive to the MFR if you facilitate a rotational movement.
That
much?
takes all of
Yeah,
this.
that feels wonderful.
You want to get the, are you back enough to see the pulling?
You're gluing. Are you pushing back or are you
Down.
Same direction as the knee.
Too much? There's more there.
If you do this twist with anybody with scoliosis, you really want to make sure that it's comfortable for them. I mean, I know what my body will do and what it won't. Some people don't know until they're in it.
It's like your own meditation.
Скажи, что ноги перестали двигать.
Come out of that one slowly. Slowly as you went in. And integrate it so they don't have a kickback. Tightening. And then sometimes this position can be like too much of a good thing, so I would suggest we shift it. So the same basic position but not as twisty. Even though that's a beautiful stretch, if you're in it too long, it can compromise and tweak anybody's back. Wow. Wow. Big changes.
Wow.
That's big, big changes.
You gonna do the other side?
I don't think so. No.
We don't have time.
She mostly needs this side.
And that's also the hip that's hiked out.
Yeah.
So you can see this gets all the way around to gluteus medius and minimus and TFL. And a lot of massage therapists don't integrate TFL as well into the picture. And then obviously we were doing some psoas release. Oh, this is still tight. Maybe, yeah, right there. You probably even catch that on the camera. That's
Yeah.
a big. That won't do. That's the last thing holding it down. So your other hand could do lots of things, but I'm going to be adding some lifting. There we go.
So your blue hand is like pulling up, right?
Yeah.
Right.
It's kind of
And it's one of those areas too that probably like 90% of massage therapists don't address well enough. So even if you've had somebody who's had a lot of massage for their hip problems, you're probably going to be the only person who's ever worked that well. And that's the kind of thing that gets people staying with you and telling all their friends.
And if you work with cups at all, it's a great area for cups. Myofascial release with cupping.
You go, Les? People get all excited when they know about psoas work.
I don't.
But the TFL does this, a lot of the same things. Oh, wow. Yay. Happiness. Wow. Holy cow, you're going to be dancing now.
In a circle.
Yank her arm out of the socket.
You have a hip that rotates now.
This is a good thing.
Hips that move.
Next time we should just pull that guy's arm way down.
Oh, yeah. Well, we aren't switching partners anymore. Keep mine.
Let me show you how that feels.
Have to get a ladder. Going in with the one lower. Do it, let's do it right.
Trisha's petite, but for somebody my size, as a therapist, anybody who is any bigger than Trisha, I would not want to try to pull this with my hands like this. I would get around and use a tool that...
This is the other one not to overlook on hip patients. Here it forms.
And I can feel the ones that we've released with my other hand, so I want to make sure whatever we're doing is not making them tighten again. That's why the trigger point here is called Huang Chao, jumping circle. Yeah. Because she keeps jumping.
So Java means circle?
You know, my Chinese Mandarin's not that good. I'm not sure which word means which. Together, supposedly, it means something like jumping circle.
Mm-hmm.
9.
What's that?
8.
What's that?
Better.
7.
Add a little hip rotation. A little MFR with my other arm. There we go. I'm glad my breakfast was a lot of protein.
Working out.
And then that definitely needs a little more integration and release. Again, a lot of areas in the body when there's something intense going on, a lot of times when you work distally, well, first of all, from a Chinese medical or traditional Asian medical point of view, it opens up the meridians, which gives the qi somewhere to go. From a fascial perspective, the fascial lines run all the way through, and it's connected, and you're opening and lengthening them. It also helps the client feel and integrate. And her chi was rising up with that, making her nauseous and going into her chest. So we need to bring that down.
Wait, you said that?
I didn't say it. She just knew. When I turned green.
You can see it in her expressions and the way she held her chest. So stomach meridian.
Her nose too found.
The stomach meridian on the leg is in the tibialis anterior, so we can work down there. You already know the 4 doors around the tummy and pericardium 6. These are all good for the tummy. And we want to bring things down. Or up and out. Clients, they release stuff. When there's stuff that's stuck that starts to come out, it can come out different ways. It can come out as toots, it can come out as nausea. You don't know what toots are, that's gas. Farts, flatulence.
I was just thinking about that.
Can come out as toots and scoots.
Hopefully not.
Calm this down and get it somewhere to go. Spleen 6 is also lovely. That's on the medial ankle, root zone above the medial border of Achilles tendon. going to touch your abdomen?
Mm-hmm.
Can you show me where your belly button is? Thank you. I'm in the point that's halfway between the solar plexus and the belly button, and the hara point, which is about 3 soon, or this far below the belly button. So the solar plexus right where the ribs come together, and the belly button halfway, and about 3 soon below the belly button. And I'm on spleen 6 with my other hand.
You're not applying any pressure.
I'm being super gentle.
Okay.
Maybe I'm just accessing the chi. I'm not being really deep. Maybe about a half a pound of pressure.
Mm.
And I'm just listening and calming. If I wanted to visualize something, it could be like something very calm, perhaps a calm, still mountain or pond. Dissipating the energy that she was letting go. And I want to bring things down to her legs because they were rising to her chest. This gives them a minute to let go and a minute to integrate the work and to relax. And the points on her tummy are going through different phases. And now gurgling, this is good. When the tummy gurgles, it's a very healthy sign of a parasympathetic response, rest and digest.
No, I'm drinking my breakfast.
Spleen 6 no longer feels effective. So I'm going to see if the kidney is more effective. This will help her let go of the stuff she was letting go in a more integrated fashion, so the changes can sort of take foot in her body and her life if she so chooses, and so that she doesn't feel so wiped out after. So the intense letting go parts of sessions are sometimes very important, but the gentle integration and rest is important too. After all, we all have our sympathetic mode kicked into effect often enough. There we go. Trisha will probably think this question is funny. Yeah, I use some Reiki.
You may do energy work on me.
I'm going to put my leg behind you.
Mm-hmm. I am not a fan of branding energy work.
is copyrighted. This is copyrighted stuff right here, yo.
Did you have to ask about the Reiki? Or
People have different opinions whether you do or not. Another reason the question is funny is because you can't really work with another human and not exchange energy, so you're like, oh, okay, now I'm going to turn on the energy, like the rest of it wasn't.
The rest is sucked out.
So now if I was a young, inexperienced, ego-centered massage practitioner, there was a lot of exciting stuff here that could release, you know? So I could be tempted to come back and release it all. But that's not what needs to happen today. Right now, that's been enough. She's had a lot of work. And so, you know, integrating, letting go, this is important.
You can tell when you got the last part. She was
Done.
done.
Bing! Timer went off. And is this position still good for you?
It's getting.
Want to be on your back for a while? Okay.
That's the lazy position on one.
All right. Turn your back for a minute.
in 4 minutes,
Do you wanna-
the number is gonna be full.
Okay, we're almost done too. Do you want something on your eyes?
No.
Okay. There's something here.
It's just my bladder.
You're very reserved when the camera's rolling.
It's a good thing.
Mm-hmm. It is.
Way to not keep me in check.
Mm-hmm. Just pretend we're filming. And so, if you're paying attention with your hands, it's not just static compression. There's going to be places that calm things down, and there's going to be places that are charged. Sometimes the charged places will calm things down if you dissipate what's there, and sometimes it's going to take you into a whole another hour of body work. So you're sort of planning your closure and exit strategy in a way that actually helps integrate and end the session for the client. So you don't want to start basically opening another can of worms or opening Pandora's box at this point. You want to help with everything that's come up so far. No client got to you in the state that they're in 1 hour, and no client will get completely out of the state they're in 1 hour. But you can help facilitate the change, and then the way they live their lives, you know, does the good bulk of it.
So it feels like 2 hours.
Who's counting?
Still another hour before lunch.
Went by pretty fast.
If you guys haven't figured it out, you've been gifted with one of the most brilliant teachers that is.
Thanks, Tricia.